Welcome, and thank you so much for joining us for another deep dive.
Glad to be here.
If you are tuning in right now, we know exactly who you are. You're the kind of person who really loves to learn.
Absolutely.
You want the thorough details, the actual substance of a topic, but you definitely don't want to be overwhelmed by a mountain of, clinical jargon.
Right. No one wants to read a textbook for fun.
Exactly. You are looking for those aha moments that suddenly make the world make just a little more sense. And today, we have a topic that is absolutely guaranteed to deliver on that.
We really do.
We're pulling from an incredibly comprehensive guide by Nikki Chase from Era Organics. It covers the symptoms, the causes, transmission, and treatment of the human papillomavirus.
It's a phenomenal breakdown. It takes a subject that is, frankly, often surrounded by confusion.
And a lot of stigma.
Yes, so much stigma and misinformation.
Yeah.
And it just lays out the biological reality. Medical terminology can get incredibly dense, and it's very easy to get lost in the weeds of viral genotypes and cellular changes.
Right.
But our goal today is to connect these clinical facts to the bigger picture of human health. We want to look at how this virus actually operates in the real world.
Okay, let's unpack this. Our mission today is to demystify a virus that affects the vast majority of the population, but still remains widely misunderstood.
Completely misunderstood.
We are going to break down the science of how it works, how it spreads, and what it actually means for your health. But before we get into those microscopic details, let's just set the stage regarding the sheer scale of this invader.
The numbers are staggering.
They are jaw-dropping. Just how widespread are we talking here?
Ubiquitous is probably the best word for it. The data shows that over 80% of sexually active people will contract this virus at some point in their lives.
80%.
Yeah. And right now, currently, there are an estimated 600 million patients worldwide carrying an active infection.
Let's just pause on that number for a second. 600 million people. To put that in perspective for you listening, that is roughly the entire population of North America plus half of Europe.
Just walking around with it.
Right now. It's staggering. And it hits a certain age group pretty hard, right?
It does. The peak prevalence happens right after the onset of sexual activity. So you see a massive spike in infections during the late teens and early 20s.
Which makes sense.
What's fascinating here is the biology of the pathogen itself, which explains why it is so incredibly successful.
Okay, break that down for us.
So when we talk about this virus, we are looking at a double-stranded deoxyribonucleic acid, or DNA virus, but it has a very specific structural quirk.
Which is?
It lacks an envelope.
Wait, no envelope. I thought viruses usually have some sort of protective outer shell to help them survive outside a host. Doesn't lacking an envelope make it weaker?
You would definitely think so, but it's actually incredibly resilient without it. It doesn't need that lipid envelope because of its specific attack strategy.
Oh, interesting.
Yes, primary target is the basal epithelial cells.
Which, just to translate that out of textbook speak for a second, that's basically the absolute bottom floor of your skin, right? The foundation.
Exactly. The deepest layer of your skin and your mucous membranes. It seeks out those specific, deeply buried cells to begin its replication process.
So it hides deep down. But another thing from the source material that really stood out to me was the regional variance.
Right, the geographic differences.
Yeah. Prevalence rates vary wildly depending on where you are in the world. It sits at around 10% in North America, but that number jumps to 21% in sub-Saharan Africa. Why such a massive gap? Is it like a different strain of the virus over there?
No, it's the exact same viral family. That disparity is a direct reflection of public health infrastructure.
Oh, that makes sense.
High-income nations see lower rates of these persistent infections, specifically because they have robust public health programs. They have comprehensive vaccination coverage and, crucially, widespread access to regular screenings.
Right, catching it early.
Exactly. In contrast, low-income countries report much higher rates because those early interventions just aren't as available. Your environment and your overall host immunity play a massive role in whether an infection really takes hold.
And when we talk about this infection taking hold, we really need to clarify something important for the listener. We aren't just talking about one single illness here.
Not at all.
It's not like the measles, where the measles is just the measles.
Yeah.
This is a massive viral family. There are over 200 distinct genotypes in this genus.
Over 200, yeah.
But obviously, we don't need to memorize 200 numbers today. How does the medical community actually categorize them to make sense of it all?
The easiest way to break it down is by looking at where they like to live and how dangerous they are. So first, you have cutaneous versus mucosal strains.
Okay.
Cutaneous strains infect the tough outer skin, so places like your hands, feet, elbows. Mucosal strains target the moist internal linings.
So the genitals, the mouth, the throat.
Precisely. Skin versus internal linings.
That's pretty straightforward.
It is. But within those categories, especially the mucosal ones, medical professionals draw a very hard line between low-risk types and high-risk types.
And that's the big distinction.
It is the most critical thing to understand today because it entirely dictates your potential health outcomes.
So let's start with the low-risk ones. What are they actually doing?
The low-risk strains in types 6 and 11 are the most notorious examples here, primarily cause benign growths.
Okay, benign is good.
Right. In fact, just those two strains, 6 and 11, account for 90% of all genital warts cases. Now, they can cause very visible, uncomfortable lesions, but they rarely lead to long-term, life-threatening health complications.
So low risk means a visible annoyance, but not cancer.
Exactly.
But then we have the high-risk types, and this is where the conversation gets a lot heavier.
It really does. The high-risk strains, specifically types 16 and 18, are terrifyingly efficient. They possess the potential to cause serious cellular mutations.
How do they actually do that? Because I've heard the term cellular dysplasia thrown around, which sounds like something out of a sci-fi movie. What is actually happening inside the cell?
Think of dysplasia as a misprint in the cell's instruction manual. These high-risk strains don't just hang out in the cell, they actually integrate their own viral DNA directly into the host's genome.
Wow.
Yeah. They hijack the nucleus of your cell and rewrite the blueprint. Instead of telling the cell to function normally, the viral DNA tells the cell to mutate and multiply abnormally.
And the real-world impact of that hack is severe.
Incredibly severe. Those two specific strains we mentioned, 16 and 18, are responsible for 70% of all cervical cancers worldwide.
70%, just from two strains out of a family of 200.
Yes.
That is wild.
It really highlights why medical classification is so important. Figuring out exactly which strain a patient has is all about assessing that specific risk for cancer progression versus just dealing with a benign lesion.
Okay, so if the high-risk strains are hiding deep in the DNA and changing our cellular blueprints, what are the low-risk ones doing? Because those are the ones people actually see, right?
Precisely. The low-risk and cutaneous strains are all about visible physical manifestations.
Here's where it gets really interesting. Let's talk about warts.
Let's do it.
We've all seen them, maybe had one on a finger as a kid, but the actual mechanics of how this virus creates them is fascinating. So the virus needs an entry point. It can't just seep through healthy skin.
Right, the skin is a barrier.
Exactly. It needs a microabrasion, a tiny cut or scrape that you probably don't even know is there. It rides that little scratch down to the basal layer, that bottom floor we talked about, and starts replicating.
And that replication triggers a very specific defense mechanism. It causes your skin cells to rapidly multiply in that one localized spot.
It essentially turns your skin cells into a hyperactive 3D printer, just piling up tissue until they form that raised, grainy bump we know as a common wart.
That's a great way to visualize it.
And here is a huge aha moment for you listening. If you've ever looked closely at a common wart, you sometimes see those little black dots inside it, right?
Yes, the ones people often mistakenly refer to as the seeds of the wart.
Exactly. I always thought they were seeds. But they are not seeds at all. Those black dots are actually tiny clotted blood vessels that have been caught up in that rapid 3D printer-like growth of the skin tissue.
They are.
The virus builds its own little blood supply, essentially.
It is a remarkable, visible symptom of a microscopic invasion. And it doesn't always look like a round bump either. The virus presents differently depending on the specific strain.
Like the filiform ones.
Right. There was a fascinating variant called filiform warts, caused by strains 1, 2, 4, 27, and 29. Instead of a round bump, these strains stimulate an overproduction of a protein called keratin.
And that creates a totally different shape.
It creates these long, thin, finger-like projections.
That sounds incredibly uncomfortable.
They can be. They usually appear on the eyelids, the lips, or the neck. They grow very quickly and are highly visible. But again, it is vital to remember these are cutaneous and benign. They do not pose a cancer threat.
We should also touch on genital warts, just to be comprehensive. They generally present as small, flesh-colored bumps or sometimes cauliflower-shaped clusters.
Right.
But the vital takeaway for you listening is that these are caused by the low-risk mucosal strains we mentioned earlier. Even if they are left untreated, they do not lead to cancer.
That's a crucial point.
They are a visible nuisance and certainly a massive source of anxiety for anyone who discovers them, but they are not the strains that cause malignant changes.
And honestly, a lot of the anxiety surrounding those physical symptoms stems from a profound misunderstanding of how the virus actually spreads in the first place.
Yes, so let's clear this up directly. Let's do some myth-busting on transmission, because the most common assumption is that you only get this from penetrative sex.
That is probably the biggest myth out there, and it's completely false.
Completely false.
The virus is transmitted through direct skin-to-skin contact. Penetration is absolutely not required. Heavy petting or any intimate contact with the genital area is more than enough friction to facilitate the exchange of the virus into those microabrasions we discussed.
And it even goes beyond sexual contact entirely, doesn't it?
It does. Because the cutaneous strains can survive on surfaces for short durations, you can actually contract them by sharing personal items.
Like what?
Sharing a damp towel or a razor with someone who has an active cutaneous infection is a known transmission route.
Okay, but let's offer some reassurance here. Before everyone listening throws out all their towels and refuses to ever shake hands again, what are the things you absolutely cannot get it from?
You cannot get it from casual contact. Hugging someone or holding hands is not a risk. And we can definitively put those old urban legends to rest. You cannot catch this virus from sitting on a toilet seat or swimming in a public pool.
Thank goodness.
Right. The virus ultimately requires a living host to replicate effectively. It doesn't just float around waiting in the pool water.
So if it requires direct skin-to-skin contact, how on earth is it spreading to hundreds of millions of people? I mean, if someone has a visible wart, wouldn't their partner just avoid contact?
They would if there was a visible wart. But this brings us to the real challenge in stopping its spread, a phenomenon known as asymptomatic shedding.
Right, the stealth mode.
Exactly, stealth mode. The virus can remain completely undetectable for months. A person might have absolutely zero visible warts, no abnormal cellular changes, no symptoms whatsoever.
They feel perfectly fine.
They feel perfectly healthy, but the virus is still active and replicating on the microscopic surface of their skin. This means partners can pass the infection back and forth repeatedly without either of them ever knowing they carry it.
Wow.
This silent shedding is the primary reason the transmission rate is so astonishingly high globally.
There is also one other transmission route that is rare, but I think it really underscores how adaptable this viral family is. It's called vertical transmission.
Yes, from mother to child.
Exactly. This happens when a mother passes the virus to her infant during childbirth. As the baby passes through the birth canal, they are exposed to the virus. In very rare cases, this can lead to a condition in the baby called respiratory papillomatosis.
Where they actually develop viral growths inside their tiny throats.
Yeah. It's rare, but it's a sobering reminder of what this pathogen is capable of.
Which naturally leads us to the timeline. What actually happens once you are infected? If it's so stealthy, how does the body respond?
Well, as we've established, for the vast majority of people, symptoms remain entirely absent. You get it, you carry it, you never know.
Right.
But when symptoms do present, they differ significantly based on the strain and the location. For women, the first sign of a deeper, high-risk infection might simply be an abnormal result on a routine Pap test, indicating those cellular misprints.
The dysplasia.
Yes. In more advanced stages, it might manifest as unusual vaginal bleeding, like bleeding between periods or after menopause, or persistent pelvic pain, which indicates actual tissue damage.
And for men?
For men, visible symptoms might include penile or anal warts. And for both men and women, if it's an oral infection from a mucosal strain, the symptoms could be a persistent sore throat, hoarseness that just won't go away, or the physical sensation of a lump in the throat.
If we connect this to the bigger picture, the timeline of the infection actually reveals the absolute resilience of the human immune system.
Oh, definitely.
Despite how easily this virus spreads and despite how efficiently it hacks our cells, the statistics are overwhelmingly hopeful. 90% of cases clear naturally within 12 to 24 months.
Let me just repeat that for the listener. 90% of people will catch this, and their bodies will just handle it within 2 years.
Yes. The immune system identifies the pathogen, produces targeted antibodies, and suppresses the viral activity without any external medical treatment whatsoever.
Which is amazing, but it forces me to ask a really specific question about the terminology.
Good.
When we say it clears, what does that actually mean for a cure? Has the body completely cured itself? Is the virus dead?
No, and that is a crucial distinction. There is a vast difference between clearance and a cure. To be clear, there is currently no medication, pill, or natural immune response that completely eradicates the virus once it has integrated into your body.
So it's still there?
Yes. When we say 90% of cases clear, it simply means the viral load drops to levels so low they are undetectable in clinical tests.
Ah, I see.
The virus drops into a dormant state. It's hiding in very small numbers within the basal skin cells. You aren't cured, but your immune system has it under such tight, complete control that it cannot cause health issues, it cannot create visible symptoms, and it is highly unlikely to be transmitted.
Okay, so the immune system basically puts it in a permanent headlock.
That's a good way to put it.
But what about the other 10%? The sobering reality is what happens when that headlock slips. If a high-risk strain persists, if it successfully evades the immune system and doesn't clear, that is when the real danger starts. The transition from a persistent high-risk infection to actual invasive cancer is not overnight, though. It is a slow, silent march that can take 10 to 20 years.
It is a massive window of time.
Yeah.
And that long window is precisely why the medical community has focused so heavily on developing ways to track it and fight back.
Yeah.
We don't have to just wait and see what happens over 20 years.
Right, we can take control. And the first line of defense is diagnosis.
Absolutely.
For women, the primary tools are well established. You have the Pap test, which is looking for the actual abnormal precancerous cell changes, the dysplasia we talked about.
Yeah.
And then you have the HPV DNA test, which is looking for the genetic material of the high-risk strains themselves. These are typically performed together as a co-test for women over 30.
And for visible growths on the skin, doctors can do a visual inspection, sometimes applying an acetic acid solution.
What does that do?
It basically makes flat or hidden warts turn white so they stand out against the healthy tissue.
Oh, that's clever.
It is. But while the diagnostics for women are robust, there is a glaring medical gap in how we handle this globally. There is currently no FDA-approved routine test for HPV in men.
None at all.
None. Unless a man develops a highly visible wart or his partner is diagnosed and traces it back, a male infection is essentially invisible to routine medical testing.
That is wild.
A man cannot just walk into a clinic and ask to be swabbed to see if he's an asymptomatic carrier of a high-risk strain. The test just doesn't exist for routine screening.
That is a massive blind spot. We are talking about a virus that affects hundreds of millions, and we are basically flying blind for half the population.
It is a profound limitation. And we face another significant limitation when we look at the treatments currently available for both men and women.
Right.
The treatments we have only address the symptoms and the physical damage. They do not treat the virus itself.
Right. Let's break down what those treatments actually look like, because the names can sound pretty intimidating.
If you have visible warts, doctors have a few physical removal options. They can use cryotherapy, which is essentially freezing the wart off with liquid nitrogen.
Okay.
Or they might use laser therapy to vaporize the affected tissue. In some cases, they prescribe an immune-stimulating cream called imiquimod, which prompts your body's local immune system to attack the wart.
And what if it's not just a wart? What if a Pap test finds those precancerous cells on the cervix?
Then the intervention gets more aggressive. They use procedures like a cone biopsy, or something called a LEEP, which stands for Loop Electrosurgical Excision Procedure.
Which sounds intense.
It's highly effective.
Isn't
Think
that-
of the LEEP like a very precise electrified wire loop. The doctor uses it to essentially scoop out the bad precancerous cells from the cervix before they have the chance to turn into full-blown cancer.
But the catch with all of these, the freezing, the lasers, the wire loops, is that they are just removing the battlefield. They are scooping out the damaged cells, but the microscopic virus still remains in the surrounding healthy skin.
Exactly. We can't cut the virus out, which means our ultimate weapon in this fight isn't treatment at all. It's prevention.
And that brings us to the vaccine, specifically the modern marvel of how this vaccine was actually engineered.
It's brilliant.
Because a lot of people are hesitant about vaccines, thinking they are going to get a mild dose of the virus. But the mechanism behind the HPV vaccine is entirely different.
It really is a triumph of modern biotechnology.
Yeah.
The vaccine doesn't use any live virus. It doesn't use dead virus. It uses something called VLPs.
Virus-like particles.
Exactly.
How does that work?
Think of it like a highly detailed decoy. Scientists take the specific surface proteins of the virus and assemble them so they look exactly like the outer shell of HPV.
Yeah.
But inside, it is completely hollow.
So there's no DNA.
There is absolutely zero viral DNA inside this decoy.
So it's biologically impossible to get the infection from the vaccine.
Completely impossible. It's essentially handing your immune system a highly detailed wanted poster.
I love that analogy.
Your body sees the decoy, assumes it's a real threat, and mounts a full defense. It creates a permanent memory of those specific surface proteins. So years later, if the real virus ever shows up, your immune system recognizes the face on the wanted poster instantly and destroys it before it can ever infect a single basal cell.
That is incredible. And the logistics of this defense are highly effective today. The current standard is the Gardasil 9 vaccine.
Right.
The 9 means it protects against the 9 most common and dangerous strains, both the high-risk ones that cause cancer and the low-risk ones that cause warts. Clinical trials show it is nearly 100% effective in preventing the related cancers if administered before exposure.
And that timing is the key variable. The target recommendation is to administer it to children and adolescents, both boys and girls, between the ages of 9 and 12.
Get it done.
The goal is to ensure this invisible shield is in place long before any potential exposure ever occurs.
It is a true investment in their future health. The cost typically ranges from $150 to $250 per dose. But it's not just for kids.
No, it's not.
It is also widely available as a catch-up vaccine for young adults, and it is even approved for adults up to age 45, depending on a discussion with their doctor about their personal risk factors.
Right, you still get it?
Because ultimately, widespread proactive vaccination is the single most effective way we can reduce the prevalence of this virus across the global population.
It's our best tool.
So let's bring all of this together for you. We started this deep dive looking at an incredibly complex 200-member viral family, a virus so ubiquitous that the vast majority of human beings will encounter it.
At some point, yes.
We've learned that while it can be a stealthy, silent invader with severe, life-altering consequences if a high-risk strain takes hold, we are not defenseless.
Far from it.
Our immune systems are remarkably adept, naturally clearing the vast majority of infections. And for the strains our bodies struggle with, modern science has provided a biological decoy that offers a near-perfect shield against the absolute worst outcomes.
This raises an important question, though.
Oh.
We spent some time discussing that glaring medical gap, the fact that there is no FDA-approved routine HPV test for men. It leaves a massive diagnostic blind spot for literally half the global population.
Right. If a man has it and he doesn't have symptoms, he simply doesn't know.
Exactly. So if we understand that silent asymptomatic shedding is the primary vehicle this virus uses to spread to hundreds of millions of people, how might this massive blind spot in male medical testing be actively shaping the secret life cycle and evolution of HPV across the globe?
Wow.
And what is it actually going to take for our diagnostic technology to finally catch up to the sheer adaptability of this pathogen?
That is exactly the kind of question that keeps you thinking long after the reading is done. It changes how you view the entire landscape of public health, and it is a perfect thought to leave you, our listener, to ponder today. Thank you so much for joining us on this deep dive. We always appreciate your curiosity and your commitment to staying thoroughly and accurately well-informed.